Dr. Angell is co-author with Dr. Stanley Robbins and later Dr. Vinay Kumar of the first 3 editions of a standard textbook, Basic Pathology. And she's also written many chapters on ethical issues. She's a member of the Association of American Physicians, the Institute of Medicine, and National Academy of Science, and many other organizations and learned bodies. In 1997, Time magazine named Dr. Angell one of the 25 most influential Americans. And in 2002, she won the George Polk Award for magazine reporting. It is indeed a great honor to have her speak with us tonight. Following Dr. Angell, Amy Whitcomb Slemmer will speak to us. Amy is the Executive Director of Healthcare for All, and I have to say I am really thrilled because I have the privilege, as does my co-teacher here, John Albrecht, of being on the Board of Directors of Healthcare for All. She's a healthcare attorney who brings more than 20 years of health policy and management experience on national and local arenas to healthcare for all. During her career, she has earned a reputation for her commitment to social justice, her ability to foster collaborations and partnerships, and for leading with passion and vision. Prior to joining Healthcare for All, she was the Executive Director of Biomedical Services for the American Red Cross in Washington, D.C., which is responsible for supplying nearly half of the nation's blood supply. As president of Slemmer and Associates Grassroots Advocacy, she provided advice and counsel to diverse groups of healthcare organizations as they negotiated the federal legislative process. During her tenure as executive director of DC Vote, Ms. Slemmer gained national recognition and attention for her advocacy efforts on behalf of DC residents fighting to have voting rights in Congress. She has served as legislative counsel for the National Association of People with AIDS and as director of public education for the Healthcare Reform Project. She began her health policy career as a member of Senator Kennedy's health staff. She graduated with honors from Wheaton College with a Bachelor of Arts degree and earned her law degree from Georgetown University Law Center. She's admitted to the Massachusetts Bar and is a member of the Washington Interfaith Network, an IAF affiliate, a founding member of Project North Star Homeless Tutorial Project, and a board member of the National Episcopal AIDS Coalition. So again, it's really a privilege and honor to have her here. Again, Dr. Angell will speak first, and followed by Amy Whitcomb Slemmer. Thank you.
Thank you very much, Wendy. Can you see me over this? I guess you can, just in the front row. You might have some trouble. I'm going to give you an old-fashioned lecture. There will be no PowerPoints, no computers. I'm going to be talking with you this evening about the future of the American healthcare system. My assignment was to look ahead 20 years, not 30, not 50, just 20, so it ought to be simple. But before doing that, I need to spend some time reviewing where we stand now and how the Affordable Care Act, aka Obamacare, is likely to affect that. It doesn't make much sense to try to predict the future unless you understand the present. Nor does it make sense to evaluate a healthcare reform effort unless you know why the healthcare system needs reform. At the end of all this, I'll do my crystal ball gazing, but I warn you, my crystal ball is not only cloudy, but split in two. It shows two mutually exclusive, long-term outcomes, one of which I strongly favor, and the other which I worry is more likely. I want to start by briefly describing three features of our current healthcare system that distinguish it from every other healthcare system in advanced countries. First, our system is uniquely expensive and uniquely inflationary. In 2011, the last year for which I have complete figures, we spent about $2.5 trillion on health care, or around $8,500 per person. And costs keep growing at 2 to 3 times the background inflation rate. It's true that the rate of increase has slowed in recent years, but most experts believe that that's due to the recession. After all, the cheapest health care is no health care at all, and that's probably what many people are now getting. What about comparably wealthy countries? If we look at the 34 members of the OECD, that's the Club of Rich Nations, we find a startling disparity. In 2011, we spent 2.5 times as much per person on health care as the average for the other OECD countries, adjusted for cost of living differences. The other countries clustered fairly close together. I mean, there was some spread between, say, Norway at the upper end and the UK at the lower end, but basically fairly close together, while we stood clearly apart, and that gap is growing. The second distinguishing feature of our health system is that we don't get anywhere near our money's worth. By all the usual measures of healthcare, life expectancy, infant mortality, immunization rates, preventable mortality, this is important. These are deaths that could be prevented with good treatment. We rank in all of these measures well below most of the other OECD countries. Furthermore, contrary to conventional wisdom, we don't provide more basic services. On average, we have fewer hospital beds and fewer doctors per capita. We see our doctors less often and have shorter hospital stays. Canadians, for example, see their doctors about twice as often as we do. As for the much vaunted high-tech tests and procedures we're all so proud of, all advanced countries have the same technologies. There are no secrets here. We just use those technologies more often, and very often unnecessarily. And more about that later. Worst of all, we're the only wealthy nation that doesn't provide comprehensive health care to all its citizens. Some 50 million Americans are uninsured, disproportionately the sick, the poor, and minorities. And most of the rest of us are underinsured, in the sense that we're not covered for all contingencies. Our healthcare system, then, is outrageously expensive, yet inadequate and inequitable. Why? How can we explain the paradox of spending more and getting less? The only plausible explanation is that there's something about the system itself, about the way we finance healthcare and deliver it, that's enormously inefficient. And here's a clue. The third distinguishing feature of the American healthcare system is that it's the only market-based system among the OECD countries. In fact, it's not a system at all, but a hodgepodge of different commercial arrangements that exist more or less independently of one another. The other countries all have national health systems. Some are single-payer systems, which means that all healthcare funds, whatever their source, are funneled through a single public agency which coordinates the distribution of resources. Some have multiple payers, but the system is tightly regulated so that everyone is covered and prices and benefits are uniform. So to recap these distinguishing features, very expensive, we don't get our money's worth, and we have a market-based system. These are the distinguishing features of our system. Now, I believe the underlying problem with the system is precisely our reliance on a commercial market in healthcare. Most of the other problems stem from that one. Alone among advanced countries, we treat healthcare like a market commodity instead of a social service. Thus, we distribute it not according to medical need, but according to the ability to pay. But there's a great mismatch between medical need and the ability to pay. In fact, those with the greatest need are precisely those least able to pay. So while markets are good for many things, they're not a good way to distribute health care, at least not if you want more health. People who are well insured may get an MRI they don't need, maybe 2 or 3 MRIs they don't need, while people without insurance may have to go without an MRI that they do need. Moreover, successful markets expand. They don't contract. Think about that. All businesses aim to increase revenues and maximize profits. Hospitals in the US, for example, you can hear it on NPR every day. They often advertise their services. Like all businesses, they want more, not fewer customers. So each element in the health market is working to grow, even though the country as a whole presumably wants the system to contract. Even on the face of it, this makes no sense. So let's look more closely at how the healthcare market works. Most Americans receive tax-exempt health benefits from their employers, who pay insurers a portion of the insurance premiums. These days, a smaller and smaller portion. But not all employers offer health benefits. It's strictly voluntary. And when they do, the benefits may be skimpy or have very high deductibles. Increasingly, employers cap their contributions so that the burden of the increasing costs of the inflation falls entirely on the workers. Workers, in turn, often turn down benefits even when they're offered because they can't afford to pay their growing share. More and more people then, in our system, more and more people end up having to pay for their own health care out of pocket in one way or another. The insurers with whom employers contract are mostly investor-owned for-profit businesses. They try to compete with one another while maximizing their own profits by stinting on medical services. That's the way they do it. The best way for insurers to compete is by not insuring high-risk patients at all, by limiting the coverage of those they do insure, for example, by excluding certain very expensive treatments, or by passing costs back to patients as deductibles and co-payments and denials of claims. We are the only nation in the world with a healthcare system based on dodging sick people. That's what we do. These practices add enormously to overhead costs because they require a great deal of paperwork. They also require creative marketing to try to attract the affluent and healthy and avoid the poor and sick. Not surprisingly then, the U.S. has the highest overhead costs in the world. Excuse me, I'm just going to have a... Now, let's follow the healthcare dollar as it wends its way from employers toward the doctors and nurses and hospitals that actually provide the medical services. First, private insurers regularly skim off the top a substantial fraction of the premiums, around 20 to 25%, for their administrative costs, other overhead, marketing, profits. Probably no more than 75 cents of the healthcare dollar actually reaches the providers, who themselves have very high overhead costs to deal with the requirements of multiple insurers, often bent on avoiding payment. In the past, there have been many attempts to reform the system incrementally. Mainly, these have been efforts to counteract the harshest effects of the market by subsidizing care to people who would otherwise go without, and discouraging demand by stratagems like managed care. But all attempts to reform the system piecemeal have run into the following dilemma. If we expand coverage, we expand access and coverage, then costs inevitably rise. On the other hand, if we try to lower costs, then coverage also must be reduced. If the system stays essentially as it is and we tinker around the edges, coverage and costs pretty much have to move in the same direction. The only way to increase health coverage and reduce costs simultaneously is to change the system entirely. With that as background, what can we say about Obamacare? I don't have time to describe the Byzantine details of the legislation, but here are the essential elements. The law encourages employers to provide health benefits by fining large companies that don't offer insurance and subsidizing small companies that do. Second, Medicaid, the program for the poor, which is jointly supported by the federal and state governments, was to be expanded at federal expense to cover an additional 16 million people. Now, the Supreme Court later said states don't have to comply with that provision. Everyone under age 65, that is, aren't on Medicare, without employer-sponsored insurance or Medicaid, estimated as another 16 million people, will be required to purchase their own private insurance policies or pay a fine. That's the mandate. But there will be subsidies for those earning less than 400% of the poverty level and online shopping exchanges for individuals and small businesses to pool risks and find a menu of approved plans. The federal website, originally planned as a backup for recalcitrant states, is the infamous healthcare.gov, which you've read about just about every single day for the last month. Now, those are the main provisions to extend coverage. But note that of the roughly 50 million currently uninsured Americans, or at least at the time the law was passed, that would still leave about 18 million, or 6% of the population, without any coverage at all. In addition to extending coverage in the ways that I've described, the law calls for regulations to curb the worst abuses of the private insurance industry, such as excluding people with pre-existing conditions, dropping people altogether when they have the temerity to come down with an expensive illness. So where does the money come from to pay for all the subsidies and the expansion of Medicaid? Where's the money come from? Well, several sources. First, the payroll tax that supports Medicare is increased for individuals who earn more than $200,000 a year, or families that earn more than $250,000. Second, these same high earners pay a 3.8% tax on unearned income, such as dividends or capital gains. Third, payments to Medicare Advantage plans are supposed to be reduced. Now, that's not really happening, but they were supposed to be reduced. These are government-supported private plans chosen by about a quarter of Medicare beneficiaries because they usually offer a broader package of benefits. The government now pays Medicare Advantage plans about 14% more than it would cost to cover the same people in ordinary Medicare. It's a real bonanza for the insurance companies that run these plans. Fourth, beginning in 2018, insurers will have to pay an excise tax on high-cost policies, which will no doubt be passed along to customers. And finally, there will be unspecified reductions in Medicare payments to hospitals and other health facilities, as well as a variety of small fees levied on health industry companies. So it's a little here and a little there. On balance, the legislation diverts money from Medicare to the private sector and Medicaid. To evaluate whether Obamacare can work, it's first necessary to emphasize yet again that the basic problem with our health system is its staggering and uncontrollable costs. Problems with access and coverage stem from that. After all, if money were no object, everyone could have all the health care they wanted, but it is an object. To work long-term, then, any reform must target costs. But to target costs, we need to know why they're so high. And there are two quite simple reasons. One, the investor-owned private insurance industry. And two, the profit-oriented delivery system. I'll say that again. The investor-owned private insurance industry and the profit-oriented delivery system. The existence of hundreds of for-profit insurance companies vying to cover the healthy and avoid the sick has created a gigantic game of hot potato, as I said earlier. That point was illustrated well in a cartoon I saw recently that shows a doctor saying to his hapless patient, "Uh-oh, it seems here that your coverage doesn't include illness." This cost shifting, along with the profits and corporate perks of the industry, is probably wasting about $500 billion this year, although there's no way to calculate health expenditures very precisely. Suffice it to say, it wastes hundreds of billions of dollars a year. But this refers only to the financing system, the way we pay for health care. What about the delivery system, the hospitals, clinics, and doctors who actually provide the care? I think we don't say enough about the delivery system, which in my view is even more inflationary than the financing system. Here again, we're unique among advanced countries in that we've left the delivery system largely in the hands of profit-maximizing providers. Even institutions that are technically nonprofit behave the same way. We have some of those in our city because they're swimming in the same profit-oriented sea. Doctors are paid fee-for-service, and the fees are heavily skewed towards specialist procedures, which is why we have so many specialists doing so many unnecessary tests and procedures, often in investor-owned outpatient facilities. And this leads me right into my favorite healthcare joke. It's actually a veterinarian joke. A woman comes in to the vet and she's carrying her pet duck, and the duck is limp. And she's very upset, and she says to the vet, "Doc, please help me. Something is really wrong with my pet duck." So the veterinarian takes the duck from her and puts the duck on the examining table, looks at the duck, and says, "Madam, I'm afraid your duck is dead." She gets very upset, and she says, "Well, couldn't he be in a coma or something? I mean, how do you know that he's dead?" So he says, "Well, okay," and he goes to a side door, and he opens the door, and in bounds a Labrador retriever. And the lad comes over to the examining table, huge dog, puts its paws on the examining table, kind of walks around the table, kind of sniffs at the duck, sits back on his haunches, looks very sadly at the vet. And the vet, "Okay," and the duck goes out of the room. And then in comes from the same side room a cat. The cat jumps up on the examining table, walks around the duck, sniffs at the duck, sits back on its haunches, looks sadly at the vet. And the vet says, "No, your duck is truly dead." So the woman sobs for a minute, and then she pulls herself together, and she says, "So how much do I owe you?" And the vet said, "That'll be $500. And the woman says, $500 just to tell me that my duck is dead?" And the vet said, "Oh, no. He says, that part was $20. He said, "But when you add the lab test and the CAT scan, it really adds up." So that's the system we have, the delivery system we have. It's probably even harder to say how much is wasted in our delivery system compared with the financing system, but I believe it's probably at least as much, maybe even twice as much. And if you doubt that, you should read the story, the lead story in yesterday's New York Times, which documents the obscene profiteering in hospitals. The problem with Obamacare, and I believe it's a failure, is that it doesn't really deal with either of the two underlying reasons for the ever-rising costs and consequent inadequacies of our health system, namely the existence of private insurers and the profiteering of providers. It doesn't truly change the system. Under Obamacare, private insurance companies will still be able to set their own premiums. And since the legislation will pour more money and customers into the industry, that's a recipe for inflation. Most of the regulations to prohibit abuses are fairly easily circumvented. And as the president of the Health Insurance Trade Association told me privately once, any adverse effect on the company's bottom line can always be offset by increasing premiums. That's what she said. As for the delivery system, care will still be provided in for-profit facilities, and doctors will still be paid fee-for-service, and the fees will still be skewed to reward highly paid specialists for doing as many procedures as possible. To be sure, there are some gestures in Obamacare toward containing costs. The law encourages the formation of prepaid physician groups that would benefit financially from providing less costly services, very much like the old HMOs that caused so much resentment in the mid-1990s. It remains to be seen whether they become common or work as envisioned. And there is some language in the legislation about determining cost-effective practice, although the law explicitly forbids time payments to the results of that research. Finally, the law calls for a committee to recommend new policies if inflation is not controlled, or for Congress to do so. But that's little more than a promissory note. These marginal efforts are overwhelmed by the initial decision to allow the private insurance industry to remain the linchpin of the system. In 2006, Massachusetts enacted legislation that closely resembles the new federal law and indeed served as its template. The Massachusetts law was originally promoted as a way to contain costs as well as expand coverage. The idea was fewer people would go to expensive emergency rooms because they would have a primary care doctor. But as costs grew even faster and at twice the rate of the rest of the country, that rationale changed. The news story is that the intention all along was just to get everyone insured in the same tent, as it were, and deal with costs later. Nearly everyone in Massachusetts now has health insurance, but the state's response to rising costs has been to cut back on the mandated benefit package and increase out-of-patient costs. Bear in mind, too, that Massachusetts began with advantages the rest of the country doesn't have: an already high rate of insurance, a special influx of Medicaid money, and a large free care pool provided by hospital and insurance fees that was tapped to subsidize the new plan. Despite all the hype that Obamacare is the most important piece of social legislation since Medicare, I doubt very much that it will ever be fully implemented as written. It's just too inflationary and too Byzantine. I'm no techie, but it strikes me that the failure of healthcare.gov website has more to do with the mind-boggling complexity of the law than with technological challenges per se. The ostensibly interlocking parts of the law will almost certainly not connect, either on the website or in practice. It's just one example. The requirement for large businesses to offer health insurance to their workers has been postponed for a year, but the individual mandate has not. So what is going to happen in the meantime, in that year, to workers working for large businesses who don't have health insurance? Do they have to buy their own insurance on the exchanges? Do they wait until the large businesses start to offer insurance? I don't know what the answer to that is. But you can see how all these interlocking parts can come disconnected very easily if they were connected in the first place. I believe Obamacare will unravel over the course of a few years as costs go up, benefits are reduced, and deductibles and co-payments are increased. Health insurance is not the same thing as health care, not by a long shot. People can have insurance that's of little use to them when they're sick. The U.S. needs a national system that provides universal care like other advanced countries have. In recent years, I've grown increasingly sympathetic to a completely nationalized health system in which there is no insurance of any kind. In essence, that would mean extending the VA system to everyone. And the VA system is now probably the most successful part of the multi-part U.S. health system. It would mean extending the VA to everyone, with hospitals and clinics owned by the federal government, which would pay salaries to doctors. This would be like the UK's original National Health Service. To its discredit, England is partly dismantling that system, although Scotland, I understand, retains it in its original form. That would be the simplest and most efficient system, and it completely separates health care from payment. Alternatively, and probably politically more realistic, we could gradually extend Medicare to the entire population by dropping the qualifying age a decade at a time. I mean, we could start right now by saying at 55, everyone is eligible for Medicare. Medicare is, after all, a government-financed, single-payer program embedded within our private market-based system. It's by far the most efficient part of our system, except for the VA, with overhead costs of about 1 to 6%, depending on whether you include Parts C and D. And it covers virtually everyone over the age of 65, not just some. It also covers everyone for the full package of benefits, so it can't be tailored to avoid high-risk patients. But Medicare is not perfect. Out-of-pocket costs are substantial and rising. Doctors' fees are skewed to reward highly paid specialists for doing procedures. Moreover, because Medicare pays for care in the same market-based entrepreneurial system as the private sector, it experiences many of the same inflationary forces. If Medicare were extended to everyone, as I suggest, it should be in the context of a non-profit delivery system. Otherwise, we wouldn't realize the advantages of a single-payer, coordinated financing system. And fees should change to reward primary care doctors more and specialists less. I can say more about this later in the question and answer, about reforms in the question and answer. In my view, health care is fundamentally a moral issue, not an economic one. Why should people who are sick or injured have to pay for that privilege? Yet that's what we make them do, as though illness were some consumer product that patients are really keen to have. So they pay twice, once in the suffering caused by the illness itself, and then again in the financial costs. To me, that's immoral, a sort of piling on. People who are sick or injured should be able to get the care they need, and money should have nothing to do with it. I sometimes wonder what it would be like if we treated education the way we treat health care. Suppose that in order for your child to enter, say, 5th grade, you or your employer needed to buy education insurance for him. If he had a pre-existing condition, of course, if he were slow or he had a learning disability, he might not be able to get it at all. But the system could be reformed. As in Obamacare, there could be 4 levels of education subsidized: bronze, silver, gold, and platinum. The bronze plan might entitle your child to study English. But with a silver plan, he could also get some history. And with the gold, maybe some math thrown in. With the platinum, who knows, maybe even art and music, the works. Of course, if you couldn't afford insurance, you'd have to check that with the IRS. You might get a subsidy. Now, that sounds crazy, right? But that's exactly how crazy our health system is. My fervent hope is that as Obamacare unravels and costs go up, the U.S. will finally be ready to embrace a non-profit, single-payer system that covers everyone, from the president on down. That's the view in my crystal ball that I really, really like. My fear, however, and the other picture in my crystal ball, is that Americans will instead conclude that providing universal health care is simply too expensive and give up on it. And I opposed Obamacare from the beginning on those grounds that it gives the illusion of reform without the substance. And people would say, oh, well, we did that, we tried that. The tragedy in that case would be that the country was too insular and too much in the pocket of the healthcare industry to recognize that good universal care can be provided relatively cheaply, as other countries have shown. Thank you.